Online, and we have a few people here as well in person. Um, so good morning, everyone. I have the pleasure actually to introduce Dr. Alfredo Walker. He's a forensic pathologist and an assistant professor at the Department of Pathology and Laboratory Medicine at the University of Ottawa, where he actually wears many hats, including being the vice chair and director of education at the Department of Pathology. And he's also the program director for the Forensic Pathology Fellowship. Dr. Walker's experience is really sought out internationally, and he has been involved as a consultant on many high-profile cases, including the George Floyd case, along with a request from the Maryland Attorney General. In Ontario, Dr. Walker is the chair of the Complex Case Expert Committee of the Ontario Forensic Pathology Services that oversees the peer reviews of all deaths in custody. And with that, I'd like to welcome Dr. Walker to giving his rounds on deaths during restraints. Dr. Walker couldn't be here with us in person, but I'm sure we'll have a great presentation from him from overseas. Thanks, Dr. Walker. Go ahead.
Yes, thank you very much. Good morning, everyone. Apologies. I would have loved to have been there in person, but unfortunately, I was required to attend a Forensic Leadership Summit here in St. Lucia. So that's where I am, and I'm presenting from my hotel room. So I was asked to talk to you guys about deaths in custody. It's a huge topic. I actually have a 3-hour presentation on it. So I basically narrowed it down to deaths during restraint so that clinicians can get an appreciation of all the factors that go into certifying the cause of death when someone dies suddenly and unexpectedly during restraint. So disclosures, as alluded to. Hello? Are you hearing me?
Yes, Dr. Walker, we can hear you.
Yeah, I was getting a feedback, so I wasn't sure. Somebody has their microphone on. Yes. So disclosures, I am the chair of the Complex Case Expert Committee of the Ontario Forensic Pathology Service, which means that any death in custody that occurs in the province of Ontario before the final report signs out, it comes to my committee that I chair for panel peer review. I am also the co-chair of the audit design team that was empaneled by the Office of the Attorney General for the state of Maryland, looking into the certification of all deaths in custody that occurred in Maryland at the Office of the Chief Medical Examiner's office as a result of the somewhat flawed testimony that was given by Dr. David Fowler, who was the former chief medical examiner for Baltimore, and he was a defense expert in the George Floyd case. And I will be making reference to a report on excited delirium, which was published in 2022 by the Physicians for Human Rights, and I was a reviewer of the draft report. So deaths in custody, whenever they occur, they are very contentious for all parties involved to deal with, be it from the investigation side of it, the postmortem examination side of it, and the certification of both cause and manner of death. There is no right answer. So by the end of this presentation, you should be able to, one, define a death in custody and all the subcategories, describe the modalities of restraint that can be employed by law enforcement officers, correctional officers, other custodians, and the risk of injury and or death associated with each modality, and specifically discuss the risks associated with certain types of restraint. So that's in custody. What is it? So it is defined as the death of a person who was in the care or custody of the police, correctional services, or who had been placed involuntarily in a psychiatric institute. So they have been placed in a psychiatric facility as a result of being sectioned, having a Form 1 filled out. And it includes the following categories of death. Death that occurs whilst being pursued by police, deaths occurring whilst in the care or custody of the police, the death of prison inmates who are incarcerated, death occurring whilst under the care of non-custodial correctional services, example, being out on bail, being on parole, or having any other community-based orders which is associated with incarceration. As well as we already said, in any patient in a psychiatric institution who was placed there involuntarily. So the National Association of Medical Examiners, which is the large US body of forensic pathologists, published a position paper in 2017 on recommendations for the definition, investigation, post-mortem examination, and reporting of deaths in custody. And in that position paper, a death in custody was defined as any death that occurs under the perceived or physical control or restraint of a law enforcement officer, a correctional officer, including private correctional officers, because they are private jails in the US, or an authorized employee or agent of a district juvenile secure facility or youth residential facility. And that includes death occurring whilst being pursued, whilst being under arrest, in the process of being arrested, in the process of being detained or under detention. Secondly, it also covers incarceration in or being committed to or on work release from a jail or correctional services or contract facility or psychiatric hospital, as well as those who are committed to a juvenile facility, as well as judicial executions. So this position paper gave a much broader definition of what a death in custody is. To inform some of the content of that paper, the ad hoc committee that was established to write it did a survey of the membership. Sorry, someone has the microphone on. Could you please turn it off? Did a survey of the membership and came up with 3 subcategories of deaths in custody. One is the pre-arrest or pre-custody phase type deaths. 2, the in-custody deaths, which occur from any time between physical arrest to incarceration, as well as the judicial executions. So the pre-custody deaths refers to any death that occurs when the decedent is under a perception that there has been a restraint of their freedom by some law enforcement agent, such as during a casual street encounter, if you're stopped, if you were detained for questioning, during a chase by law enforcement, be it on foot or in a vehicle, or even during a verbal standoff with law enforcement and someone, succumbs to sudden cardiac event and collapses, sudden arrhythmic death, that's still classified as a death in custody, albeit in the pre-custody phase. So therefore, this subcategory includes all deaths that occur prior to the application of any physical restraint that may be associated with the process of being arrested. The in-custody deaths refer to those deaths that occur in the interval extending from the point of physical contact between law enforcement and the subject of the arrest to being released from jail or in prison. So any deaths that occur within that phase is classified as an in-custody death, and therefore it refers to all deaths that occur whilst in the actual physical custody of the police, the correctional services, or other agencies. And under this subcategory, there are 5 further subcategories: arrest phase, transportation phase, booking in phase, incarceration, and deaths occurring whilst in an infirmary undergoing healthcare treatment. So arrest phase, that's self-evident, death occurring during the physical struggle on apprehension of an individual. Transportation phase death refers to deaths occurring from transportation of a subject from the scene of an incident, either to a police station, a jail, medical facility, inclusive of being transported in an ambulance. So not necessarily in police custody for transportation, but it's still classified as a death in custody once you have been arrested. Booking in phase, so that refers to deaths occurring during the processing of an arrested individual during transfer from the custody of the law enforcement officer who conducted the arrest to handing over at the police station to the booking officer, to the jail or other temporary housing facility or correctional facility. The incarceration deaths, well, once you are behind bars and those bars have been closed, have been locked, and you die in a cell, that's an incarceration death. And it may also include the death of an individual who has been released from incarceration, but may have died from injuries sustained whilst in police custody. The prototype example being if the arrest was violent or there was some altercation during your period of incarceration, you sustain a blunt force head injury, develop a subdural, which only manifests itself 4 to 6 hours after sustaining it, but within that time interval, you were released and then you die, and it has established that you died as a result of a blunt force head injury sustained whilst you were incarcerated. That is also classified as an incarceration death. Judicial executions, this defines any death occurring in a jurisdiction in which judicial executions are legal. So these are court-mandated executions, be it by hanging, lethal injection, firing squad, or electrocution. All these convictees, when they are executed, they have a medical legal post-mortem examination to confirm the cause of death, and the manner of death in these cases is always classified as homicide. Homicide in the context of medical legal death investigation simply means death occurring at the hands of another. It does not infer any criminal liability, because judicial executions are all state-mandated, court-mandated. The executioner, the person who pulls the trapdoor, who flicks the switch to administer the voltage that causes death by electrocution, they will not be prosecuted despite the manner of death being classified as homicide. Manner of death refers to, it's a quasi-judicial statement that refers to the circumstances in which a death occurred. And in forensic pathology, there are 5 manners of death. Natural, meaning it's due completely 100% to spontaneously occurring natural disease processes. And then you have the unnatural category, which could be suicide, if there's deliberate, intentional self-harm. Homicide, again, simply means death at the hands of another, or accident. And if there are more than one equally competing of those 4 manners, or we just cannot establish a conclusive manner, then we use the undetermined or unascertained category. There are many guideline documents for investigating deaths in custody. These are two examples. Here, on the left is the handbook from the International Committee of the Red Cross, and on the right is the United Nations, the Human Rights Section publication known as the Minnesota Protocol for the Investigation of Potentially Unlawful Death, and this refers to the investigation of deaths as a result of torture at the hands of states, players, etc. When it comes to the postmortem examination of these cases, they are complex. They're not straightforward. There are many factors that affect the analysis of a case. But first and foremost, we as forensic pathologists need to know as best as possible the sequence of events that led up to the death, during attempted restraint, during incarceration, during arrest, as well as the nature of any methods of restraint which has been used. Secondly, there must be an understanding of the physiological processes which may have been operating at the time versus the paucity of contradictory physiological evidence of cardiorespiratory changes that we know to occur during severe stress, physical stress, emotional stress, drug toxicity stress. There is difficulty sometimes in ascribing relative significance to the effects of therapeutic and illicit drugs, which may be in the system of the victim at the time of the incident. And as far as the postmortem investigation goes, postmortem toxicology is fraught with many caveats. Toxicological analysis of blood in living people is not the same as toxicological analysis of blood from decedents. There are entities like postmortem redistribution that occurs where drugs that have a high volume of distribution and can be highly tissue-bound come out of their tissue-bound state back into the blood at death. So a drug that was in a therapeutic concentration or a non-toxic concentration in life, because of postmortem redistribution, may end up being in a toxic range in a postmortem blood sample. And there's no way for us to correct that given the current state of knowledge on postmortem toxicology. As well as some substances undergo degradation after death. Cocaine is another prototype example. Cocaine can continue to be non-enzymatically degraded in the body after death, such that if there's a prolonged interval between an incident and death, and the postmortem examination, you may find that there's no detectable cocaine and high concentration of its metabolite, even though cocaine would have been at a significant concentration at the time of the incident, as well as pharmacological tolerance to certain types of drugs. People develop tolerance to it, and there's no way that we can physiologically correct or toxicologically correct for tolerance. So just having a number in terms of a concentration cannot accurately predict the pharmacological effect it would have had on the individual in life, because we cannot correct for tolerance and individual variability. Pre-existent natural disease, having severe underlying heart disease, lung disease, etc., could have significant contributions to the mechanism of death, as well as the effects of very complex neuropsychiatric syndromes, the agitated syndromes, the delirium type syndromes. And then on top of that, you may have the effects of superimposed trauma from being physically restrained, chemically restrained, electrically restrained. And there is always the problematic assessment, as I said before, the relative contribution of each of those preceding factors to the fatal outcome. So let's look at restraint. So what is restraint? So restraint refers to different methods which can be employed to establish an acceptable balance between minimization of the risk of injury to the subject under control, as well as to maximize effectiveness of the rapidity of bringing them under control. Broadly, there are three main categories. There's physical restraint, there's chemical restraint, there's sedative restraint. So restraint refers again to those modalities used to effect control of an individual to facilitate arrest. And if we look at the modalities of physical restraint, they can be further broken down into three types. Manual, those that involve the use of implements, as well as those that involve the use of conducting electrical devices. Manual physical restraint may include prone positioning with or without supplemental applications of ligatures around the wrist, around the ankles, neck holds, which nobody should use as a restraint method because they inherently carry some form of risk of causing death, or any other physical method to incapacitate, such as applying pressure to the back of an individual who is in the prone position on the ground. Implements, so these are hand or leg cuffs, ligatures, you have restraint suits, spit hoods, the use of batons to administer blows to the body, firearms, standard firearms, impact rounds, which just are created to induce pain and not kill, Kevlar belts, etc., as well as the conducting electrical devices, the best known of which is the taser, as well as stun guns. Modalities of chemical restraint that can be used are lacrimal agents and chemical irritants. So agents that are used to induce lacrimation and pain in the eyes, and chemical irritants such as pepper spray, as well as sedative drugs. So physical restraint, handcuffs, prone positioning, the hog-tied or hobble position, which we will see just now, applying restraint to the extremities while in the prone position, as well as applying downward pressure on the back to someone who is restrained in the prone position, and then using spit hoods. These are impervious hoods over the head to prevent the subject from spitting or biting the individual. So handcuffs, well known, they're used around the wrist to prevent the victim from using their hands. No real inherent risk of causing severe injury or death if they're used on the front of the body. When it comes to being restrained in the prone position, we have to be conscious of the physiology of breathing and what occurs at the cardiopulmonary level. So we know on inhalation, the ribcage expands to increase its volumes, to allow the lungs to expand, diaphragm contracts, and air is inspired, and at the alveolar level, there's an exchange of oxygen and carbon dioxide. And within that cycle, you have pressure changes that occur between the different chambers of the heart. During short periods of maximal exercise, ventilation of the lungs can increase almost 20-fold, from about 5 to 6 liters per minute in the resting state to about 150 liters per minute as a result of hyperventilation. Respiratory rate goes up from 16 to 20 breaths to about 40 to 50 breaths per minute. And the depth of breathing also goes up by about 4 to 6-fold, from 0.5 liters per breath to about 3 liters per breath. There is a accompanying increase in cardiac output that also occurs of about 4 to 6-fold as well. So there's significant increases as a compensatory mechanism under hyperventilation. During periods of hyperventilation and anaerobic metabolism, you have a metabolic acidosis that develops as a result of the inability to clear carbon dioxide from your system. And there are two big contributory factors to that: the impairment of the ventilation, especially in the prone position, because the chest is compressed, if force is applied to the back, there's resistance to the upward movement of the diaphragm and the outward expansion of the rib cage, as well as there's a decrease in cardiac output. The increase in intra-abdominal pressure impairs venous return, so you cannot increase your cardiac output. So inherently, again, you have cardiorespiratory effects in prone positioning that results in a metabolic acidosis and can be associated with sudden death during the process of being restrained in the prone position. And the most recent literature on that has defined it as prone restraint cardiac arrest. So stress, excitement, agitation, physical exertion, and the presence of stimulant drugs can all interact, if they're all present at the same time, to increase the metabolic demand on the body, which necessitates an increase in oxygen consumption by the tissues, an increase in production of carbon dioxide, and an increased cardiac output as compensation. And if your normal ventilation of the chest is impaired because you're being restrained in the prone position with pressure applied to the back of the torso, those compensatory mechanisms cannot take effect, and you develop metabolic acidosis, for which hyperventilation is one of the effects to treat with it. And hyperventilation will facilitate blowing off carbon dioxide as a means of resolving that metabolic acidosis, changing the pH of the blood. You guys would know this graph much better than I do, but it shows what happens to oxygen consumption on the x-axis related to ventilation on the y-axis in the setting of anaerobic metabolism and at rest. And you can see that the demand goes up. In normal breathing, an inspiration, we use the intercostal muscles and the diaphragm. Expiration is passive. And when we have tachypnea, in addition to the intercostal and the diaphragms, you also use the accessory muscles in an attempt to increase the volume of the chest cavity, and the internal intercostals and abdominal muscles are also recruited in expiration, again, to facilitate in blowing off. So this diagram attempts to show what happens when someone is restrained in the prone position, pressure is applied to the back, and the hands are restrained. So the chest wall is splinted, it cannot expand, the rib cage cannot expand, the diaphragm cannot move upwards to allow for the increase in the volume of the chest cavity, and there's a decrease in venous return because of the increase in intra-abdominal pressure. Put a morbidly obese person on top of this scenario with significant underlying heart disease, ischemic heart disease, hypertensive heart disease, severe coronary artery narrowing, etc., then you can see how the milieu for an adverse outcome will occur. So we discussed the pathophysiology of a metabolic acidosis occurring in this situation. And when that occurs, you tend to get pulseless electrical activity or asystole as your initial rhythm, which is in contrast to other rhythms that you will get if there is a primary cardiac issue. So pulseless electrical activity can be caused by the 5 H's and the 5 T's: hypovolemia, hypoxia, increase in hydrogen ions or acidosis, hypo or hyperkalemia, and hypothermia. The 5 T's: tension, pneumothorax, trauma, tamponade, pulmonary thrombosis, thromboembolism, or coronary thrombosis. There is this restraint position called the prone maximal restraint position, otherwise known as the hog tie or hobble restraint position. And in this position, handcuffs are applied to the wrist and the back of the body. Shackles are applied around the ankles, and then a ligature then connects the handcuffs to the ankle shackles. Again, this is just making a bad situation already worse. And as I said, on top of this, add a morbidly obese person with a very, very protuberant abdomen, underlying heart disease, and you can also, in your mind's eye, add the effect of methamphetamine, cocaine, other stimulant drugs with exertion, the person struggling in this position for a number of minutes. This position has a real potential to cause death, and it has caused death from that interaction of those multiplicity of factors. These are other variations of it. So the lower limb is flexed at the knee at a 90-degree angle. And here there's an acute angle. I mean, you know, none of us could see ourselves being comfortable in this position for any period of time, even at rest. So the physiological effects of that prone maximal restraint position is that this can produce significant metabolic acidosis, which can result in death, although those who have conducted studies on this have reported that no clinically important limitations of either metabolic or ventilatory function are seen in generally fit volunteers after 60 seconds of maximal struggling in this position. So they take healthy volunteers, army recruits, etc. They put them in that position. They attach ECG electrodes and pulse oximeters and get them to struggle for at least 60 seconds and say, no, nothing to see here. All the parameters remain within normal. So this position isn't inherently fatal. Unfortunately, in forensic pathology, the people who succumb are not the fit and healthy ones who have no drugs in the system, who are not morbidly obese, who, you know, and don't have heart disease. So this is the most recent publication on prone restrained cardiac arrest, in which the thinking has moved away from restraint asphyxia, inability to breathe as the mechanism of death in these positions, to prone restrained cardiac arrest as a result of the development of a metabolic acidosis from the inability to hyperventilate and blow off carbon dioxide. So Elon Steinberg, his paper is on the left. He's a cardiologist in Los Angeles. So it's a very good publication. If you all want it, I could email it and share it with you. Prone restrained cardiac arrest, a comprehensive review of the scientific literature and an explanation of the physiology. And then on the second paper that he published together with Victor Whedon, again, another former chief medical examiner of OCME Baltimore, where they had, I think, 3 such deaths in which there was clinical information that supported this mechanism before they died. So from this second paper, the highlights that come out is that prone restrained deaths result from metabolic acidosis, not hypoxic asphyxia. The metabolic demand is increased by the presence of stimulant drugs, physical exertion, and stress. Metabolic acidosis requires hyperventilation as the antidote to blow off the excess carbon dioxide, and prolonged restraint in the prone position may prevent the blowing off of the carbon dioxide. In those cases in which paramedics respond and apply ECG pads, any initial rhythm of PEA or asystole after cardiac arrest is generally inconsistent with an underlying primary cardiac pathology as the cause of the arrest, and it's more likely pointing to the metabolic acidosis. And we went through that slide of the 5 H's and the 5 T's. So let's move to neck holes. So neck holes are another physical restraint method that can be employed to temporarily incapacitate or render an individual unconscious. And there are 2 types of neck holes: the bar or choke hole, which applies enough pressure to restrict the airway, so you want to compromise breathing, or the stranglehold or carotid sleeper, which is applied on both sides of the neck to compromise arterial blood flow. You want to compress the carotid to prevent blood flow to the brain, thereby invoking unconsciousness. So this is what they look like. Any attempt to forcibly compress the neck carries an inherent risk of producing a fatal outcome. There is no safe way, really and truly, to do this, despite what you may see in, wrestling, etc. These can prove to be fatal. So on the left, the bar or choke hole is applied from behind. The forearm is applied across the front of the neck. Pressure is applied in an anterior-posterior direction, front to back, and you're trying to compress the airway to prevent breathing. On the right, the arm and forearm are used in a pincer grip style, where pressure is applied from side to side. You use the free hand to lock the hand that is forcing that pincer grip, and you're applying pressure from left to right and right to left, with the aim being to compress the carotid arteries. Recently, another publication by a series of neurologists in the US, they showed that the carotid artery supplies 70% of the cerebral blood flow. It provides about 600 to 700 mils per minute. And, if there is compression of it, such that this is reduced, decrease in cerebral blood flow is the most important mechanism for invoking loss of consciousness. There is the potential for an adverse outcome when you compress the neck as a result of either dislodging emboli to cause embolic strokes from the carotid artery, dislodgement of arteriomatous plaques, invoking seizures, and all of these can result in death. The implication from their analysis is that there's no safe way for law enforcement officers to restrain persons using carotid manipulation or traumatic manipulation of cerebral blood flow, especially in the setting of all the underlying adverse contributory factors that we discuss. Why? Because there's always a potential for neurological sequelae to develop from oxygen deprivation, the risk of embolism or mechanical trauma, as well as inducing arrhythmias. So their 2021 publication in bold there basically says that the current understanding of the brain, its physiology, carotid neurophysiology, and the clinical effects of carotid compression does not support the safe use of chokeholds or strangleholds by law enforcement as a physical restraint modality. So and that expands or extends to anybody who has to physically restrain someone, be it a patient in a hospital, a psychiatric patient in a mental institution. Putting your upper limb around someone's neck is inviting trouble. Manhandling is another term that's used to refer to the application of blows to the body, submission or chokeholds application, tackling them to the ground, using body weights of officers, etc., to pin an individual onto the ground in the prone position. The outcome is dependent on the type, duration, and amount of force applied and where it's applied, the anatomical region. The face, the neck, we saw what happened in George Floyd, the torso or the appendages. That can occur whilst being restrained in that manner. And although it would fulfill the old criteria for positional asphyxia or restraint asphyxia, the now understanding is that it's metabolic acidosis, and we will tend to call those prone restrained cardiac arrest. And the main question that a cardiac pathologist has to consider when he's certifying cause of death in these cases is, did cardiorespiratory collapse occur during the active restraint or shortly thereafter? There is a period of peril within a few minutes after the cessation of the physical exertion that you are still at increased risk, where your catecholamine levels are coming down and your potassium is going up. You can develop a fatal arrhythmia in that period. It's called the post-exercise peril period. So someone could actually survive the active restraint, but collapse shortly thereafter. Spit hoods, what are we doing for time? It's 8:15. So spit hoods, these are impervious membranes, which are used over the head to prevent the victim, the suspect, from spitting at law enforcement or biting. And they can contribute to deaths. They can lead to asphyxia when used in conjunction with all the other modalities. And it's more difficult for first responders to monitor breathing when they are applied. If the victim is bleeding from the nose or mouth, or they're vomited within the split hood, that can clog the mesh and actually prevent breathing and contribute to asphyxia as a mechanism. So the take home is that it's potentially dangerous to restrain a subject in a prone position with a split hood mask in situ. Again, if you take the context of all the other things we have discussed to this point, this is just making bad matters worse. And to exemplify that, this is a recent case from 2020 in Rochester, New York, in which this guy Daniel Prude was having a psychotic episode in the street. He's naked. He was restrained by law enforcement. They applied a spit hood over his head. And guess what? He died. Sickle cell trait has been invoked in some quarters as an explanation to absolve law enforcement of any culpable actions. The position is that people with sickle cell trait don't go into a crisis spontaneously as a result of their disease without any contribution from all the precipitating factors. So sickle cell trait is not considered a significant ancillary contributor to death. Lacrimal agents, things like pepper spray, CS gas, etc., they have a potential for invoking bronchospasm and respiratory compromise in susceptible individuals. So again, these should be used with caution or not used at all. There is a move in the US for paramedics to administer neuroleptic drugs like haloperidol, etc., dissociative anesthetics, ketamine, benzodiazepines, at the request of law enforcement when they turn up on the scene of an incident and people have died shortly thereafter. These drugs are supposed to be used in a clinical setting where the effects can be properly monitored. They have no place as a modality of restraint as a sedative in the setting of an aggressive physical restraint, plus or minus all the other things that we have discussed. Conducted electrical weapons. So these are used to, one, either invoke pain, the stun gun, which is directly applied to the skin, and a high voltage, low amp current is applied to invoke pain as a means of control, or the taser, which can be fired from a distance. You have two barbs which are deployed and make contact with the individual. Again, a high voltage, low amp current is applied, and that induces involuntary contraction of skeletal muscles by stimulating the alpha motor neurons and causes them to fall to the ground. So they lose voluntary control of their muscles, they fall to the ground, and they can be arrested. So when we are faced with sudden death during restraint, they are multifactorial. And it's not unreasonable to postulate that restricted ventilation superimposed on extreme, prolonged physical exertion on top of hypoxemia, lactic acidosis, the catecholamine surge, hyperkalemia are all potentially lethal, either alone or in combination with other factors such as pre-existent underlying cardiovascular disease. Add the effects of compression of the neck on top of that, as well as excited delirium. And Houston, we have a problem. So over the years, restraint asphyxia was used to certify these. As I said before, the modern thinking is that it's prone restrained cardiac arrest from metabolic acidosis. But this entity of excited delirium was sometimes invoked by medical examiners as a normal, a natural occurring entity that would be used to absolve law enforcement of any culpability. So I'm conscious of the time. I'm just going to try to quickly give you an idea of what excited delirium is, and then we'll stop. So it's a controversial entity that was used to describe a situation where a person in an irrational state displays violent behavior with a potentially fatal state of extreme agitation and delirium. It first appeared in the medical literature in the 1800s. First paper was by a psychiatrist, Bell, and it was known as Bell's mania. And it re-emerged back in the 80s during the cocaine pandemic, and it was used in a 1985 article in the Journal of Forensic Sciences by a publication from Charles Wetley, a forensic pathologist, and Fishbane, a psychiatrist, both of whom were in Miami, who described cocaine-induced psychosis followed by sudden death in 7 recreational drug users. The risk factors are prior use of large quantities of stimulant drugs, those who are mentally ill, those who are non-compliant with their antipsychotic meds. They exhibit bizarre behavior in a public space or not that draws the attention of law enforcement. They then fail to respond to the commands of law enforcement, and that necessitates the use of some force to apprehend them for their own safety and for that of the public. They tend to display superhuman strength and appear impervious to pain, meaning that pepper spray don't work, stun gun, the tasers don't work. So this is Charles Wetley, and this is the publication. And later on, there became a movement to use this terminology as a means of explaining death when people die during restraint. So it was invoked as a cause of death in cases where death occurred during or shortly after restraint, and in that way, law enforcement were absolved of any culpability. Then, in between September 86 and November 88, the bodies of 12 black women who were presumed to be sex workers were found in the same region of Miami. Wetley and colleagues found that almost all of them had low concentrations of cocaine on their postmortem toxicology and certified the manner of death in the majority of cases as accidental from recreational cocaine intoxication. And later in 1988, he began to publicize it, and he put forward what was known as the cocaine-sex theory, and said that these deaths had resulted from a combination of sex, orgasm, and the stimulant effects of cocaine. He stated categorically that the autopsies had demonstrated conclusively that these 12 women hadn't been murdered. Went on to say that in black men, cocaine causes psychosis, but in black women, they die from the effects of cocaine and sexual excitement. And this is a direct quote from him. For some reason, the male of the species becomes psychotic, the species, and the female of the species dies in relation to sex while using cocaine. But then people ask, so why are black women dying? Because Caucasians, Asians, everybody was using cocaine at the time. So he then, in response, speculated without any scientific basis that we might find out that cocaine in combination with a certain blood type, which is more common in blacks, is lethal. And then this girl died. A 14-year-old girl was also found dead in the same area. Her autopsy was performed, and he believed that she too had died from a combination of sex and cocaine. But guess what? No cocaine was detected. So her relatives pushed back on that. A complaint was then put in to the chief medical examiner, who reviewed by then a total of 19 deaths and reclassified all of them. They were all reclassified as homicides. Apparently, Wetley had missed obvious signs of asphyxia, be it manual strangulation or smothering in these cases. And the chief forensic pathologist, Dr. Joe Davis, who reviewed it, said you could see these pathological features from 10 feet away. It was that clear. But despite that, Wetley perpetuated, he persisted in peddling this cocaine sex theory and excited delirium, and it became ingrained in the forensic pathology literature. It wasn't accepted by the mainstream medical organizations, the only two entities that recognized it, the National Association of Medical Examiners and the American College of Emergency Physicians. And then in 2020, Physicians for Human Rights decided to do a deep dive into this entity to determine whether it was considered real or not. And the end result was the publication of this report, Unexcited Delirium, that came out in March 2022, that basically says it's a baseless diagnosis. It cannot be disentangled from its unscientific and racist origins, and it should not be used as a cause of death. And eventually, the two organizations, the National Association of Medical Examiners, as well as the ACP, had to issue position statements that basically walk back the acceptance of it. So the PHR report shone a light on a baseless diagnosis, and it made NAME and ACP backtrack on their acceptance. And although these are steps in the right direction, there's still a lot of work to be done as far as educating law enforcement and other first responders are concerned. So I'll just skip to the end because we closed out of time. And for you guys as clinicians, I just want to say that restraint can be associated with fatal outcomes. Some persons are at an increased risk of sudden death during restraint based on their underlying state of health, their intoxication status, and the manner or modalities of restraint that are used. Careful consideration should be given to the application of any of those modalities in all cases. And for us, as forensic pathologists, when fatality occurs, the investigation of those cases at the postmortem and the certification, the accurate certification of cause and manner of death is a complex activity. It's not straightforward. And no one should assume that the cause of death is the underlying heart disease because the patient had heart disease or the underlying lung disease. All such cases should be referred to the coroner for investigation. And on that note, I will stop there to allow for some questions.
Thank you, Dr. Walker, for the wonderful talk. I have a few questions actually on the chat. I'll read them out so that everybody can hear them. Dr. Chan is asking, how frequently is Takotsubo cardiomyopathy or stress-induced cardiomyopathy considered a cause of death in a person during a strain?
So stress-induced cardiomyopathy is a clinical diagnosis. We cannot diagnose that at postmortem because there are no pathological changes that we can see in the heart to make that diagnosis. It's something that exists in the clinical literature, but no forensic pathologist would invoke that as a cause of death because we cannot prove pathologically that it exists either grossly or microscopically. It's supposed to be a functional abnormality from the outpouring of catecholamines.
Thank you. Comments as well as two questions from Dr. Beanlands. He just wanted to thank you for the excellent and informative talk. And the questions are are there or what steps can we take and what approaches exist to prevent escalation for a patient with delirium when it comes to trying to handle them on the wards as they don't follow command? And then the second part is that, are there educational strategies in hospital settings when faced with situations of accentuated delirium or violent behavior that can prevent, escalation?
So I am not the best person to ask about strategies for de-escalation. You probably need to speak to law enforcement. So, there is law enforcement training in that regard. All I can say is that for combative patients, there's now a move that the response should not be primarily a law enforcement response. It should be a psychiatry response. There should be some member of the psychiatry team involved in these responses. They should accompany paramedics, the police, etc., and assist with the de-escalation. That's the new thinking now. I can't give you any protocol because I don't know it offhand, but I'm sure if you contact the Canadian Police College, the OPP Training College in Ontario, they must have something in their manual on de-escalation. Unfortunately, I don't have that. I don't have that magic bullet. And what was the second part of the question?
The second part was just the educational strategies, but I think you're gonna say the same thing.
Yeah.
Yeah.
All I can say in a hospital setting, if a patient wants to leave the hospital, there should not be any serious attempt to try to physically prevent them from leaving. I know there's probably a concern that, they may end up harming themselves, etc. The intentions may be good, but you can have an adverse outcome by trying to prevent a patient from leaving. So, the Ottawa Hospital has to come up with a strategy. If it's just contacting the next of kin to say, Miss X or Mr. Y is attempting to leave the ward, we cannot physically prevent them from leaving. We are just letting you know, call the police, alert the police, etc. But I don't think that hospital staff is best placed to try to restrain these people from leaving.
Okay, well, thank you very much for the talk. If no other questions, I'll let Dr. Walker get on with his day and the rest of everybody to get on with their day as well.
Okay, thank you very much. I hope it was helpful.
Thanks again, Dr. Walker. Bye-bye.
Bye.